Yes, already.
Good morning, good afternoon, and good evening, depend on which part of the world you are at now. I am Huafeng Wei at the Department of Anesthesiology and Critical Care at the University of Pennsylvania at Philadelphia. I'm also the president of the International Airway Management Society, IAMS. On the behalf of IAMS, welcome and thank you all to attend this second international virtual case discussion on difficult airway management. I would like to take this opportunity to thank the host institute, the host, the presenter, the expert panel, and the volunteer that make this happen, especially for transfer from Zoom meeting to live broadcasting. And I also like to take this opportunity to thank all the IAMS board members, founding directors, members, and the colleagues and collaborators from other society, such as Difficult Airway Society, Society for Airway Management, European Society for Airway Management, and Chinese Society of Anesthesiology Airway Management Group, All India Difficult Airway Society, and etc. Around the world. I really appreciate everybody's support for the development of the IAMS. And for the volunteer, I like to say a lot of people in China has a volunteer to prepare this. Um, this is the majorly doctors Jimmy, Cindy, Chen, Tingting Wang, Qiao, Yong Wang, Xiaoliang Wang, Bailin Jiang, and Dr. Liao, Liao Chuan from China. They are translating summary of the meeting and to the Chinese audience in the live broadcasting. And for those who are not familiar with the International Airway Management Society, I'm now play a short video for introduction of our society. And So that's the video. So for today's agenda is the next. I will present today's host from Ukraine, and then the host will introduce presenter, and then start the presentation, and then the panel discussion from international expert panel and the expert in this Zoom. Then the host will pick up some question on the chat, either from Zoom or from the live broadcasting. Some are translated questions and summarized and translated to the Zoom chat. So it's my great pleasure and honor to introduce today's host, Maksym Pylypenko. Max is a professor at Department of Anesthesia and Intensive Care at Sukhi National Medical Academy of Postgraduate Education. The head of the department is Professor Oligo Losputo, and this is, as I learned, it's a famous department and institute in Ukraine. And I know Max a couple of years ago, and because we share same interests on the jet ventilation, and he is also one of the founding director of IAMS, and that institute is one of the IAMS assisted training centers around the world. He is a very experienced anesthesiologist and also takes the critical care. I attended the BAS meeting, US, like in the collaborated with England. It's a very nice meeting. I hope that we can visit the department in the future. So now I will ask the Max to take over the control, and he will introduce his institute and the presenter more. And also Max is one of the two presenters today. Thank you, Max, for your help and for your support. All yours now.
Dear ladies and gentlemen,
now. Stop sharing.
Dear ladies and gentlemen, good morning who are in States, good afternoon in Europe, and good evening to all Asia. I'll try to introduce our today's team briefly. We are thankful for choosing our case for presentations, and just right after our presentation will be shared in two parts, main from Dennis and very small part from me. We will have our discussion, and with great pleasure and with great honor, I would like to present our expert panel. And at first, I would like to present Professor Alistair McNarry from Western General Hospital from Edinburgh, UK, and his consultant and Western General and John's Hospital and leader of UK's national audit. He's organizer of UK's national database for front of neck access, and he is well-known expert in expert committee of Difficult Airway Society. Next is a great expert is Huafeng Wei. She's professor and chairman of Department of Anesthesiology and Pain and first hospital of Nanjing and Nanjing Medical University. She's a leader and leading consult in Jiangsu province and honorary professor simultaneously in Edge Hill University, United Kingdom. And he's a leader expert in technology in Nanjing province. And finally, we will present well-known European expert, Professor Nuzhet Mert Senturk, from Department of Anesthesiology and Intensive Care from Istanbul and present Istanbul University, and he is the first editor of Turkish Journal of Anesthesiology and Reanimation. And without any further delay, I would like to present my colleague, whom I know for, let's say, more than 15 years. Dennis Pokryshen is one of the leading anesthetists from Institute of Otolaryngology, National Academy of Medical Science, and we are glad to present such interesting case. Please, Dennis.
Thank you very much, Max, for your kind introduction. Good afternoon, dear colleagues, or good morning or good evening. It really depends. It is just better to say hello, I think. My name is Dennis Pokryshen, and I'm anesthesiologist. I work in Kiev in the institution that deals mainly with head and neck surgery. It is called Otolaryngology Institute. You can see it in the picture. It is kind of like tertiary institution that covers the whole country, and the most complicated, the most advanced surgical ENT cases end up in our operating theaters. I've been working there for more than 10 years, mainly in the department that focuses on the treatment of laryngeal pathology, like papillomatosis, laryngeal stenosis, bilateral vocal fold paralysis, phonosurgery, etc. And obviously working in the environment like that in laryngology, we have interest in airway cases from time to time. But this time, this one, I think it's really somewhat special. It's absolutely unusual. And in my opinion, it is worth sharing and discussing even on international level. Before I start presentation, I'd like to say that it is well known that impacted laryngeal foreign bodies could lead to severe airway obstruction and catastrophic consequences. It is sort of a common knowledge, everyone knows that, but perhaps it is not always so. And in the case we present, a large foreign body impacted in larynx caused only mild or at maximum mild to moderate airway obstruction. A 40-year-old male weighing 70 kilos was admitted as an emergency to our institution. On examination, he appeared relatively asymptomatic. He had several mild complaints, like hoarseness, difficulty swallowing oral secretions, and mild shortness of breath at exertion. On examination, it is important to mention that patient...
Excuse me, Dennis, have you shared your PPT?
Yes, it's Dennis PPT. Is it clear?
Can you see our screen? Sorry.
No, not yet.
Yeah.
Please.
Can you share your PPT?
No.
Just a minute. Just a second. We will try to share it. So we try to use demonstration of the screen. If it's available, such option, please let technical organizers to confirm, because I'm pressing several times on
I didn't see.
screen.
Did anybody else see the PPT? I didn't see your PPT. You can share the screen like we in our rehearsal practice. So the your PPT will be here.
Yes, is it okay now?
Now it's coming.
It's starting. Yeah, right now
okay.
we have.
Okay.
Perfect.
Okay, let it be like this.
Okay. Start from the beginning, please.
Okay. 40-year-old male weighing 70 kilos was admitted as an emergency to our ENT institution. On examination, he appeared relatively asymptomatic. He had only several mild complaints like hoarseness and difficulty swallowing oral secretions and mild shortness of breath at exertion. It is important to mention that a patient came to the admission office basically on his own, without any referrals and without ambulance, and he couldn't remember what had happened to him. And for this reason, we also didn't have a clue. We didn't have any idea. And honestly speaking, a large foreign body was the last thing we were thinking about. We just couldn't imagine that. And again, his condition was more or less stable. He maintained oxygen saturation of 95% on room air at rest. He could easily sustain basic physical activity like walking across the ward, from bed to chair in the radiology department as well. Apart from history of smoking and occasional alcohol consumption, he appeared to be otherwise fit and well. ENT surgeon decided to perform endoscopic examination, and absolutely unexpectedly, all of a sudden, flexible endoscopy demonstrated a large foreign object, presumably a set of teeth. Honestly, it wasn't immediately evident what was that. And only after a video record was examined in slow motion, frame by frame, we could make out that it was a set of teeth trapped in the larynx. Interestingly, as I've already said, he couldn't recollect any circumstances of what happened. He informed us that approximately 2 days before admission, 48 hours before admission, he had been drinking or let's say consuming alcohol-containing beverages with his friends. They were having a party, and that's all. Basically, it could be anything. He couldn't recollect any other circumstances of injury. Possibly it might have been a street fight or something of that kind. But anyway, it's just pure speculations. Computer tomography confirmed diagnosis, and we could be sure after that what it exactly was. I'd like to put an emphasis on the fact that these scans, especially the last one, they suggest airway obstruction. Although in reality, at the same time, clinically, we didn't observe any desaturation or any other symptoms of severe airway compromise. An hour later, he was taken into operating room for microlaryngoscopy. Our plan A was to use Thrive, transnasal humidified rapid insufflation ventilatory exchange, for pre-oxygenation, induction, and maintenance. And our plan B was a surgical tracheostomy. And we had a team of 3 laryngologists, including the most senior one, prepared for it and ready to cut the neck should it become possible, should it become necessary. Standard monitors were attached, and pre-oxygenation started with 40 liters of oxygen. Then we induced with propofol, fentanyl, and suxamitonium. We didn't use a face mask ventilation during induction, only jaw thrust and Thrive. And for this reason, we didn't check initial CO2 level. Immediately after induction, surgical laryngoscope was inserted, and flow of nasal oxygen was increased up to 70 liters per minute. We used total intravenous anesthesia for maintenance of the whole procedure. With some technical difficulties and after several futile, unsuccessful attempts, surgeon eventually managed to grasp the object with forceps. As dental bridge was too large to go through the laryngoscope lumen, forceps with foreign body and laryngoscope were removed altogether. After that, laryngoscope was reinserted for inspection and control of bleeding, which wasn't quite heavy at all. I have to say, just a couple of drops. Surgical intervention amounted to 18 minutes. And we gave additional bolus of succinylcholine somewhere in the middle of intervention. When surgery was over, laryngoscope was removed and LMA was placed for conventional ventilation until recovery. At the end of surgical intervention, capnography demonstrated end-tidal CO2 of 54 millimeters of mercury, which is not high at all. Recovery was uneventful and patient was transferred to the ward safely. We observed him overnight and discharged the following day. Well, teaching and learning points. In my opinion, the most interesting, the most important fact about this case is that such a large object impacted in larynx, which is the narrowest part of human airway, may lead only to mild or at maximum mild to moderate airway obstruction, which is interesting and unusual. Also, airway obstruction is a well-known limitation of SRIVE, of transnasal humidified rapid insufflation ventilatory exchange, when it used as a method of respiratory support for airway procedures. And we knew that, we kept that in mind, and provided that we expected that SRIVE might not have been that effective during procedure. But it turned out that it was. Oxygen saturation was 100% and CO2 increase was only up to 54 millimeters of mercury. So we didn't have any problems at all. So SRIVE was effective in this case, which by implication suggests that airway patency was preserved throughout procedure. We assume that the object itself, probably due to its shape and position, the dentition had a slightly convex concave shape. Probably because of this, it possibly helped to maintain airway patency and prevented vocal folds from complete closure in laryngospasm. In addition, I would like to emphasize the importance of preoperative evaluation. Flexible endoscopy and computer tomography provided valuable information that helped us to manage this case successfully. Speaking about possible alternatives, obviously it goes without saying that any kind of airway management that requires passing something through the vocal cords is impossible in this case. And the tracheal intubation and subglottic catheter placement, anything. Supraglottic jet ventilation delivered via surgical laryngoscope also, in my opinion, cannot be effective because jet delivered from above would crash against foreign object and therefore won't deliver effective ventilation. Tracheostomy, well, we made all the necessary preparations and it was our plan B. We got the most experienced surgeons ready for it. But the question is that tracheostomy is an invasive procedure. And for this reason, it was only the second option for us. Preventive transtracheal cannulation. It could be considered as a reasonable alternative, probably with subsequent transtracheal jet ventilation, should it become necessary. But the question is at what level to puncture, because in this case, you definitely can't go through the membrane because the foreign object is right in the larynx. You need to puncture somewhere below, probably between the second and the third tracheal rings. And then train via transtracheal cannula. We don't have any experience with this technique with Ventrain, but I think that it requires sealed airway up to a point. So it had to be complete, probably near complete airway obstruction, but I'm not sure about this because we don't have any experience with this technique. We're not familiar with it. And supraglottic jet oxygenation and ventilation is also a possible alternative as it combines high flow oxygen with supraglottic jetting. While making this presentation, we searched literature for similar cases, and we found only few publications reporting more or less similar conditions, and they are cited on this slide. Thank you very much for your attention, and it will be a pleasure for me and for Max to listen to your comments and suggestions. Thanks.
Thank you very much, Dennis. I'll try to show, let's say, a low-end presentation after such high-end one, and arise a few simple and maybe also important question. First of all, about the patient. Patient probably was lucky, or maybe it was some God grace or God providence that first he came to the best institution in Ukraine, probably the only place in Kyiv and maybe in Ukraine with such machinery and with such experience, and patient came at the daytime. What will be if a patient will come in another hospital and during the nighttime? So we would, let's say, share some best presentation, and if organizers make available our presentation, we agree to share with you. The most important questions, what's a problem with foreign bodies, especially large, and who has to deal with it? And only then we have to put some more precise anesthetic questions. And concerning terminology, such fatal cases are called fatal cafe coronary, and in these articles, it's underlined that only up to 1/3 of fatal cafe coronary causes with object in larynx. Second name is fatal choking, and in this article is underlined that most of patients are small children or advanced adults with some impairment of consciousness, or another, as it in our cases, some alcohol or drug intoxicated cases. And third name of this conditional, especially of fatal, is like bolus death. It's in such articles is underline the causes. It could be meat, fruits, and much more rare such teeth as in our cases. Maybe the best publication is very recent October publication in Medscape, where it's underlined that approach has to be started with ABCD, and at first it has to be revealed whether obstruction complete or not complete. In terms of tracheal, whether laryngeal obstruction, it's better to be treated in appropriate institution, and it has to be focused where the object located in the upper airway or in the lower airway, and most of publications are devoted to the tracheal or bronchial location. First, ABC or ABCD approach, finding airway threatening or life-threatening condition, and we have to understand some confounding factors like agitation, alcohol intoxication, full stomach, and potential of vomiting. In some cases, even Heimlich maneuver and some blowing for the back is ineffective, and it's certainly ineffective in some eggs in larynx or some needles, flower like schistol in the larynx. What's new that if you have some ineffective Heimlich maneuver or some blows on the back, you could use gravity facilitated positions, and authors make conclusion that even after several Heimlich maneuvers attempt, when patient put it upside down, the obstruction could be released or treated. Sometimes it's due to facial trauma, especially combat facial trauma, and in military literature, it is focused that patient has to be in comfortable position right up to the very procedures. Only when everything is ready, patient could be sedated and put it in another position that comfortable for his breathing. This Medscape underlines that rigid bronchoscopy and especially rigid laryngoscopy is much more effective than flexible bronchoscope in terms of fixing and withdrawing the object. So just example of rigid bronchoscopy, and the most reliable device is such suspension laryngoscope, which is obviously not available even in my emergency hospital. So the specialist from another hospital has to be invited quickly, or patient has to be transferred right to the appropriate hospital. What else is underlined in literature? Everybody has to be ready for surgical airway, but it's not so simple as Denise just mentioned. It is some good sides from ENT surgeons, and ENT guys are those who are ready. And could you see about oxygenation? It could be first nasal oxygenation to facilitate work of ENT surgeons. And concerning the bronchoscope, not every clinic has such forceps, snares, baskets, and so on. So you have to recognize it. Another important point is that if patient is intubated, for example, it's usually impossible to pull such objects through endotracheal tube, even through rigid bronchoscope, even through a much more wider rigid suspension laryngoscope. And endotracheal tube, bronchoscope, or laryngoscope could be, and in some most severe cases has to be removed with, together with object, and airway management has to be complete once more after that. And ENT guys looking on infection rather on just efficacy of such, they are looking on different complications, including infection and perforation and bleeding. So don't forget to try to involve such guys if you have any opportunity. And after we disclose all ABC aspects, we could continue our discussion just for our anesthetic questions. And our question: what is the level of sedation? Usually it's the less stated topic in anesthesia, and only procedure sedation guidelines could show us how we could choose appropriate dose. Only few of anesthetists are brave enough to relax these patients, but it could be absolutely necessary to use mere relaxants. And if we have relaxated, how to keep oxygenation, and if anesthetist or anesthesiologist is alone, how he has to deal it himself with normal laryngoscopy, video laryngoscopy, or if he has to wait as much as possible when the ENT or other specialist will come. Okay, thank you for your attention. And now, with great pleasure, I would like to ask to comment and maybe to give some questions from our panel experts. Please welcome.
Thank you very much. Thank you to Dennis. Thank you to Max for your wonderful presentations. They were very interesting. Congratulations on all the work that you've put into them.
Thank you.
Thanks.
Can I just say that the highlights of the presentation for me were
please.
twofold. Number one, Thrive is fantastic. I'm a great Thrive fan, but I was delighted that you had a plan should Thrive fail. We all see all of these presentations, and I've given several myself, saying, isn't Thrive marvelous? Doesn't it give us all these wonderful opportunities? But I was genuinely delighted that you thought about what's going to happen to us if Thrive is unsuccessful. How are we going to manage this? And you had a team ready to do a tracheostomy. And I think the other thing that really pleased me, Max, when you were talking about the issues, was the fact that you identified saying, where is the foreign body? As part of that process of planning and deciding what anesthetic you're going to give. Because clearly the position of the foreign body will greatly affect the anesthetic you want to give, but also the anesthetic you're able to give. And to me, those are the two highlights. Thrive is a fantastic option in cases like this, but Thrive can fail. I was looking back at a case series from our own hospital, and we reckon Thrive can fail about 5% of the time. And having a plan B in those situations is really, really important. So those are my absolute highlights. I don't want to hog the floor. And I want to give my other experts a chance to contribute, but a very impressive presentation. Well done.
Thank you, Alistair. We are grateful for your summary, and maybe we will have a discussion, and we are certainly keen to listen to you again.
May I ask you a question, Alistair, about transtracheal jet ventilation in this situation? What do you think about it?
I think the key thing about transtracheal jet ventilation is, if you go back to the literature, if you go back to Ravisson's work, if you go back to some of the big French series, it is a dangerous technique in its own right. You have to be experienced at doing it before you can do it successfully and before you can do it in an emergency situation. And of course, the key thing about transtracheal jet ventilation is, where do you put the cannula? You don't want to kink the cannula simply because you're impinging on the foreign body. So do you go a ring lower? How can you be sure the cannula's in? Have you checked it's in? Are you experienced with your jet ventilation mode? Do you have a high frequency jet ventilator with alarms? Are you using a low frequency jet ventilation system? You need to be in a hospital where there's experience not just from the anesthesiologist, but also from the surgical team in using a jet ventilation system. Jet ventilation is safe, but there was a wonderful study by Tim Cook and his colleagues a couple of years ago that found that the incidence of complications with jet ventilation were at their least in centers that were doing more than 100 procedures a year. And so jet ventilation, a bit like Thrive, it's an expert technique. You wouldn't want to be undertaking it in the center that wasn't used to doing it. And really safety here is all about the experience of the operators with the technique that they're using.
Thank you, Alistair. Okay, we would like to approach our other expert panels. Professor Bao.
Can I follow? Can I have a comment? Follow Alistair's comment about the TTJV. The TTJV has selective and emergent. For the emergent, the TTJV is used for emergent airway. That's have a high incidence of barotrauma. It's about 35%, and also failure rate about 64%. As the Alistair said, that the major issue is experience. A lot of people never have experience on TTJV, then emergent difficult airway, they have to do it, and they mostly fail. The other thing is elective TTJV that you plan. There is a report from University of Alabama show that in 88 cases, in the majorly all the throat cancer, the patient coming in for a week track, but patient short of hypoxemia around 80 because the cancer in the throat, and they do awake, but what they did is a elective transtracheal jack. So they did the local, give a little bit ketamine, patient awake, breathing, and they do transtracheal jack using the triple lumen expander. So in 88 cases, they use manual jaculator, they use low frequency. The 88 cases, they don't have any barotrauma. So it fully depends on your experience. That's really, it's when people think transtracheal jab, they always think it's dangerous because of barotrauma. But if you had experience, you plan well, you know the mechanism, it can be very valuable in emergent elective difficult airway. So compare with HFO in this case, I think the advantage for transtracheal jet is below vocal cord. So you have reduced the risk to blow the foreign body into the trachea. You're supraglottic, right? If you have a high, I don't know how high the flow or high the pressure of supraglottic jet will push foreign body further into the vocal cord. I know yours probably not going to the trachea because of the big foreign body. But if it's, what about a small one or some food, when you have a high pressure, high flow above a foreign body, that have a risk to push it down, right? But the transtracheal jet basically has the pressure in the trachea. It will resist to this foreign body moving further into trachea. And that's maybe one of the advantage if you use below the vocal cord oxygen. And also it will secure the ventilation oxygenation probably better than above the foreign body. Because you think about it, if you use supraglottic jet, it may, if the foreign body is the base, it may block the jet flow. And the high flow might be better because it can go through the side of the foreign body. The other thing I'm not sure is about aspiration. I think a transtracheal jet may, because of the pressure in the trachea, it probably reduced the aspiration. But the upper one, if you use high flow in the nose or supraglottic jet, whether the patient is not an NTO, has a high aspiration risk, that's whether it's increased aspiration in this patient. That might be discussed. Yeah. Thank you.
Thank you, Huafeng, for valuable points. And ask to say something our experts. Professor Bao, could you say your points for this issue?
Okay, thanks for Dr. V's organize this conference. And also thanks for Daniel's wonderful presentation. And thanks for doctors summarize. Well, it is a global problem for the foreign, body choke in the airway, especially in China. Some children suffer this kind of problem, such as the peanuts or coin, inspiration or choke in their trachea or in their airway. So most of the time we can use like a first aid way to help, such as we can use harmonic menu or back blues or stomach or abdomen thoracic. But sometimes it is difficult to take the foreign bodies out. We need to anesthesia. For this kind of patients, normally we will use, the surgeon will use a regional bronchoscope procedure. They will need, very deep anesthesia or general anesthesia. So for us, we normally, for the kids, for the children, we will use isoflurane or C4 to help. For the for the adult, we will use intravenous. However, before we start, the first things, pre-assessment is important. We will see which kind, foreign body choke in the airway or choke in the throat, and use X-ray and or use scoop to assessment. Second, we will make the plan, like first choice, and if failed, what's the second choice to do that, especially when the patient is emergency cases. So we need get a plan. Then the third one, we need teamwork. Actually, we couldn't say who do the job to take the foreign bodies, because sometimes it is knife throating, and anybody like an ENT doctor can do that, but anesthesiologist can do this as well, especially if the the foreign body choke in the main trachea. So the main thing is to try to sever the patient's knife. We can use the prone position or head down, and to help. If we can't, we sometimes we will do more sever patient's knife way. By the way, sometimes if the foreign body choke in the tracheal lung, may cause infection. So we will be careful, cause another complications. And that's my opinion. And thanks for inviting me.
Thank you, Professor Bao. The preparation, making plans, and especially to communicate aloud, to say on what stage are you, how do you consider your, let's say, ability to oxygenate in this moment, because on spontaneous breathing, it could be higher, even on some middle or moderate level of sedation, the ability of oxygenation could be dropped very quickly. So to have a plan and to know what everybody has to do is very valuable addition to our presentation and to all future cases. Okay, Professor Senturk, could you please express your view on this point?
Thank you very much. I think you can hear me. First of all, that was a great presentation. Thank you very much. I will focus again, like Alistair, on two things. First of all, Thrive. Thrive is indeed perfect, and I want to, okay, this is not the topic today, but the topic of the days that we are living. Thrive is not perfect for our daily business, the COVID. And even today, there was a chat with our colleagues from Switzerland, Mark Licker. He's a famous thoracic anesthetist, and he said too, and this is also the case here in Turkey, during the first wave of COVID, we were afraid. So the physicians were afraid of using TRIVE because of the risk of aerosolization, because of the high flow, very high flow that could cause some aerosolization. But now we have seen that it is very effective and very less invasive than mechanical ventilation. And during the second wave, all the countries, or many countries, are using TRIVE for COVID. And therefore, that's a great system of management for TRIVE. The good thing on it, I just want to repeat, we all know it, because of the high flow, it's somehow different than the apneic oxygenation. And it was also the case in the case that you have presented. We have, although you have done some repeated succinylcholine doses, so the patient is not breathing, the CO2 level was still low. So at least not as high as we would expect with an apneic oxygenation. The reason is the high flow with this TRIVE can reach some washout of the CO2 in the airways, and this can cause also, this can lead to an CO2 elimination without a respiratory report and effort, and that is the good thing on it. Therefore, TRIVE is perfect, especially in these days. If we would behave like in the first wave of COVID, in this second wave too, we would exhaust some 20 days ago probably. We couldn't survive with this second wave. The second thing that I want to underline is that indeed it was a big luck of that patient that he has showed teeth set, and as you have expressed too, that was his luck indeed. The shape was something indeed to keep the airway open, and therefore we have been successful in that case. That was a great luck of you, and especially a great luck of the patient. Probably if this was not a set of teeth, a very solid, rigid U-shaped thing like this one, this would be very problematic, and therefore it is a very interesting and very lucky case, I think. Thank you.
Thank you, Nuzhet. TRIVE is really come up even in Ukraine. We have no such devices, but this month it's just started to come to Ukraine. But ENT institution and maybe only 1 or 2 clinics were lucky to have such TRIVE a few years ago and to reach some experience. But we appreciated your point of high flow, and beside nasal cannulas, it could be some other device like children's endotracheal tube or Wei tube designed by Professor Wei. But the main question is how can we recognize and what is the point to understand the level of sealing, because patient was certainly lucky that larynx was not complete sealing. But do we have some symptoms or let's say some tests to recognize beside just saturation? For example, some examination, even CT showed that larynx was obstructed, but it wasn't. Maybe some points on the questions how to recognize a sealing, and is it possible to recognize besides spontaneous breathing or not?
Very good question. I would like to say something here. I really think in that case, the very interesting tube designed by Professor Wei, this Wei tube, we can see that also the CO2 level, if we can see an untitled CO2, that would be a sign that the airway was not sealed, as you have said before. And that, therefore, I think this could be a very good idea to use these tube in these cases too. But in that case, it was not necessary, obviously.
Thank you. I have some comment in just a publication in India Journal of Anesthesia last year by Susan Gupta. Is a very good review comparing high flow nasal oxygen or thrive compared with supraglottic jet oxygenation ventilation. I think in terms of oxygenation, the mechanism is same. If you have SGOV frequency high enough, let's see above 100, or the flow, if you calculate, it will be in the range of high flow. I think it's from 40 liter per minute to 70, right? And my belief, the oxygenation mechanism is same. Even patients do not have breathing effort, but because of the oxygen diffusion, and it can maintain oxygenation. That has been showing in both high flow nasal oxygen and the supraglottic jet oxygenation and the ventilation. And the difference is the CO2. I think in the previous study, the Strive, if you paralyze patients and you use the Strive, oxygen has no problem, like on average 26 minutes in the paralyzed patient, some are 17 minutes. The O2 can be maintained above 96%, but the CO2 is proportionally going up as the time going. So they had CO2 accumulation. For HGOV technique, if the jet pulse facing the vocal cord, around the vocal cord, if you have a chest rising in a paralyzed patient, there should be no CO2 problem. And you also have CO2 monitor. And so that, I think, is the difference. But for this particular case, when we use SGOV, I'm worried about if the foreign body can be brief. If the foreign body is smaller enough, whether it's safe to use SGOV, and then you can blow the foreign body from in the throat area, maybe past the vocal cord into the trachea. That makes problem more problem. So that had to be considered, and to see what kind of driving pressure you need to use. I saw a publication also in India Journal of Anesthesia using SHOV in similar case on the foreign body removal in the throat, but they used only look like only 6 liter per minute oxygen, not the really jet, not high driving pressure jet. The other thing I want to follow comment with Mert about the risk use of HFNO in COVID-19 patients. I think probably you notice with the 2 IAMS meeting on the website with the contribution of 16 authors from 12 countries, including here Mert and Matt, and I saw Ross is here. So we have an editorial in PGA just published. So this examines 3 controversies in COVID-19 patients on airway management. One is definition of classification of PPE. So we gave a photo and clearly clarified 3-level PPE based on the publication up to now, the level 3, which need combined use of both eye goggle and face shield and protective gown. That gives majority of the study give 100% protection of healthcare workers. But those only used in China. In the rest of the world, in Europe, in America, basically we are level 2. On the level 2, there's an international study and Europe study, American study, study from South Africa. It looked like the infection rate of healthcare workers from 4 to 11%. Although we have difficulty to maybe get the protective gown available to make the level 3. So the majority, the clear definition of level 3, level 2 is level 3 has no skin or eye exposure to outside, and level 2 has some skin or eye exposure to outside. That's what practiced in the U.S. and Europe. So I think at least we can use both eye goggle and face shield together when you do airway management. Right now, we are only required to use either face shield or eye goggle, not both. But I think if you both get a both, will be better protection if you don't have protective gum. That's one controversial topic. The other major one is whether high flow nasal oxygen increase risk of cross-infection of healthcare workers. The conclusion is it's not fully clear, but the majority of studies did not demonstrate it increased the risk of healthcare worker the infection, because that's the major issue. Use HFNO in the COVID-19 patients because people worry about increased cross-infection. However, we recommend this based on benefit risk ratio that if you use level 3 good level PPE, use enter room, and HFNO may look like increased studies show increase intubation rate, maybe decrease mortality or improve outcome, although this is not fully confirmed. So this editorial in British Journal of Anesthesia, recently published, has been broadcasting by Newsbreak, by a lot of news medium. I said, if you have time, it's a very good article you can read. And this is a contribution from 16 international experts of 12 countries. I want to thank all the co-authors for their study. So that's my comment on that. Thank you.
Okay, thank you, Huafeng. To deal with such a case in COVID era would be much harder to use all PPE, especially level 3. But we can discuss the questions. For example, in 99% of Ukrainian hospital, rigid bronchoscope and especially suspension laryngoscope is not available. And my questions for the panel and for audience, could you please say, are you going, could you start this case, managing this case, if you have just anesthetic equipment, for example, a laryngoscope and some bronchoscope without rigid bronchoscope? The question is, such questions important, or please let express your opinion concerning necessity to have rigid bronchoscope or suspension laryngoscope to start anesthesia for removal.
I'll go first, if that's all right.
Alistair.
I think it's not about whether you can have a go. It's about having the patient in an area where the procedure can be managed safely. Now, your patient walked into the hospital, so they were declaring themselves to be stable. You don't quite know whether an adjustment of the foreign body in the larynx would have caused a change in that stability, but they were essentially stable. They weren't hypoxic. You didn't give any impression they were in respiratory distress. In that situation, it is important that actually you don't cause them any harm in the first instance. And so the have a go with what you've got doesn't really apply. You have to say, okay, we're either going to have to move staff or resources to the patient. And I appreciate that's not going to be easy. And some of our listeners are going to say that's going to be impossible. But where it is at all possible, this is a stable patient. You can afford to wait some hours to get the right equipment and the right personnel to perform the procedure. Having a go with what you've got is actually when people get into trouble. Mainly because, as we kind of alluded to earlier, The key thing is, what are you going to do when it goes wrong? What are you going to do halfway through a semi-sedated flexible bronchoscopy if the patient suddenly desaturates and you're on your own in your own hospital without any support or backup? And so the strategy has to be, make a plan. It may be in extremis, you have to get on with it. You have to presume that the foreign body is going to be retrievable from the larynx, or you're going to have to do some sort of frontal neck access. But that's an extremis plan. In a semi-elective setting that you're in at the moment, where the patient isn't an extremis, you owe it to the patient to not rush in, where actually best practice is to stop and make, as you did, a plan and a second plan, and have the expertise available to deliver it.
Thank you, Alistair. Do somebody have another point to share with us on this topic, necessity to run or to wait and prepare better?
Ross Hofmeyer has some comment here. Maybe we can read it. Do you want me to read it? I can read Ross Hofmeyer.
Yes, please.
Yeah, please.
Yeah, I'm online, so I'm happy to chime in. Yeah, so I wholeheartedly agree with Alistair. In this presentation of this patient who was not in extremis, who was effectively stable, then moving the patient into a setting where you have all of the tools available and 360-degree access to the patient, and as I like to say, hot and cold running surgeons, that is the best situation that you can ask for, and we should always manage our patients in the best setting that we can. In my center, we do have access to suspension, to rigid bronchoscopy, to Thrive, to jet ventilation, although not high frequency jet. And so that, I would bring this patient to theater, and that's how we would do it. I do work in a country which has got a very, very wide spectrum of levels of care that's available. And so it's not very hard to go an hour or two's drive down the road to a center in which we wouldn't have that equipment available. And if the patient's in extremis, where you'd have to manage with what you have and make do. And I think in that setting, I've certainly, in resource-constrained settings, done quite a number of foreign body retrievals from the larynx and the immediate subglottic region using video laryngoscopy, ideally using a hyperangulated forceps like a Bodecker forceps, otherwise normal McGill's. And I think also, in addition to that, it behooves us as airway anaesthetists to be reasonably skilled with devices such as rigid bronchoscopes. And a rigid bronchoscope is a very robust and a very transportable piece of equipment. It's something which can be carried with a portable light source and can be used in a very resource-constrained setting. So that's my bias. If you can, always move the patient to the most ideal level of care. If you can't, with modern devices such as good quality VL, or even with much older devices such as rigid bronchoscopy, if you're skilled, many of these situations can be resolved.
Thank you, Ross. Any other points to share, please?
One thing is this kind of patient may be a lot of time. If it's not emergent, you might wait until your aspiration rate significantly decrease. But if it's emergent, how do you balance the sedation, general anesthesia, especially muscle relaxant use, if you want to use rigid scope, and with the aspiration rate, how to be balanced? It's probably a very tough situation. If the patient, let's see, it's a high aspiration rate, that's the E, and the foreign body really make it hypoxemia is needed. We need a remedy right away. How should we proceed on the anesthesia?
I think in 90% of cases, anesthesiologist will reserve myorelaxants till the very end, maybe if nothing else helped. But our colleagues just show us that early using myorelaxants was correct answer. And using myorelaxants is directly connected with machinery you have, with availability of such contemporary oxygenation methods. And another questions, I don't know, maybe somebody have experience about local anesthesia, whether some local anesthesia could be helpful to perform, for example, a video laryngoscopy with a lower level of sedation in case you have no drive, and if you have only such intermediate way of oxygenation like a normal nasal cannulas. Dennis has his opinion on this issue. Please, Dennis.
Yeah, actually using myorelaxants is our common practice, and it was stated in many previous papers, like NAP4, for instance, that muscle relaxants can help to maintain airway patency and can help to maintain successful oxygenation. So my choice in this situation and in any situation like that, to use muscle relaxation as early as possible, provided that all the necessary equipment for plan B and C and so on is available, of course. And pre-oxygenation is an important point, because when you use muscle relaxant, it is essential to pre-oxygenate well in advance. We have basically many laryngoscopies, and I think that many surgeons just wouldn't be able to insert suspension laryngoscope without proper relaxation. It is also important. I think talking about local anesthesia in this case, possibly, again, it's just my opinion, I could be wrong here, but I think it may worsen situation, because any additional manipulations in airways may lead to some unexpected consequences, like laryngospasm, like secretions, and so on and so forth. And when such a large foreign body is already in larynx, I would be very cautious about using any additional manipulations in this area, like before the whole procedure is started, because it may cause desaturation and may worsen the situation.
Thank you, Dennis. Professor McNarry has written something to add concerning myorelaxants, please.
I was going to just talk a little bit about the idea of awake video laryngoscopy as a way of retrieving the foreign body. Awake video laryngoscopy is a great technique, but it's again something you have to have practiced. You have to understand the differences between a topicalization with video laryngoscopy. And I do agree, you don't want to distress this patient anymore. You don't want them coughing unexpectedly, and you don't want to cause them any distress. That's very different. I'm just going to say, back to your original presentation, to the benefits of nasendoscopy, so you know what's going on at the level of the cords. So the idea of a fine bore camera seeing what's going on, very different to the topicalization you require for something like awake video laryngoscopy. So nasendoscopy to find out what's going on, great idea. Video laryngoscopy awake, particularly in inexperienced hands, probably not such a great idea. And even in experienced hands, there'd have to be a clear indication that it was the right thing to do.
I agree with Alistair that if this patient has a high risk of aspiration, and if you induce paralyzed, aspirate. You know that aspiration is by NEP4 is the leading cause of anesthesia death. 50% of anesthesia death coming from aspiration. So that had to be really careful. So the a weak follow-up intubation, those technique local, although in this patient, if it's a weak, if it's not in the immediate danger, that may, especially for hospital without an advanced technique and maybe remote area like in China, they can difficult to transfer patients. That if you have a good focalization, patient a little bit of sedation, that you use whether you use the soft fiber optic scope and something video scope can try to take it out, whether that's might be a safer way for those without all the backup tracheostomy or rigid scope or high flow nasal oxygen hospital. The problem now is people gradually have less training on the focalizing the oropharyngeal area or do the nerve block that make it on the weak fiber optic intubation smooth because we don't use it that much. I haven't been using a weak fiber optic intubation for a long time. But when I was resident at Penn, we used it a lot. Because that time we don't have video scope, we don't have all the advanced technique. So the safest way is to use a weak fiber optic intubation. I think in the airway medicine meeting this year, I reviewed an abstract from Allison's department, and he said that the training for a weak fiber optic intubation has been significantly impaired, but that's really needed. And sometimes this is the safest way that manage airway, although it takes time and maybe patient maybe suffer a little bit. But I think that need the training of a weak fiber optic intubation need to be maintained, at least when you really need it, probably it will be helpful.
Okay, thank you, Huafeng. We have a question about TRIVE. Is it effective with OSAS? It's some obstructive, maybe sleep apnea, yes, and large foreign body occlusion of the glottis. Very different cases, but similar pathogenesis and similar, let's say, mechanics. Who could deal with such question? Who has some experience in OS sleeping apnea?
Well, I think that if this patient happened to have some additional comorbidities like obstructive sleep apnea or morbid obesity, obviously situation would be different. But our patient was quite slim, BMI 27. So it gives us like additional advantage because morbid obesity and obstructive sleep apnea are well-known limitations. And THRIVE would be effective as long as airway is open. Okay, good.
Airway open, we have to check, and especially patient position, because if the head is in sniffing position, it's another situation. If patient has some shortage to extend his or her hands. But in terms of such obese patients, we could discuss maybe the cut point to plan D to front of neck access. Please, could you share your experience of prediction, which level of saturation led you to come up to front of neck access, whether it has to be 70 or we could try to use and try to do something at let's say 60. What is the not return point to go straight for the front of neck access? Please, colleagues.
Yes, somebody asked, is Strava effective for patients with ulcer and for the large foreign bodies occurring on the glottis? We just did some research study about that for Strava used in the fatty or big patients. We found it does work, and the condition is we should keep the airway open. That is also for the very severe ulcer, such as some patients, we still keep the patients wait but use scoop to intubation. Just depends. Yeah.
Thank you, Professor Bao. And if airway, if we can't make airway open and keep airway opens, what would be your what would be the saturation that you will decide to go to the conicotomy or even tracheostomy, in this case much useful? Do you have any saturation in your mind that usually push you to cut the neck?
Okay, that is a good question. And first, the position is important. Looks like the open airway, looks like the smell something. Second, we use with narrow from the nose put in, and also use like from small number until to 7 or 8 numbers, and we call it with nausea caster to help. And sometimes we use Strava, and most of the time actually we use Strava to help, and that is really I should say useful to help the patients, especially for the big patients to do. Even some patients we do the keep the conscious to do intubation. We use Strava to give the oxygen to support and make the oximeter keep higher. So I just feel Strava is a good way and also effective for the ulcer patients. But another question for the large foreign body, sometimes we really need assessment, because in my hospital we made some denture stuck in the trachea, and then when the ENT take it off, cause the bleeding and hurt, because this denture has some metal there. So like assessment is important, especially for the emergency cases. Only one doctors or one like ENT doctor, anesthesiologist, sometimes very, very difficult. All right, thanks for
Thank you, Professor Bao. And Professor McNarry, could you please express your thoughts about prediction of TRIVE failure in especially obese patients, and maybe your, let's say, cutoff level for front of neck access if the failure is obviously...
A brief thing on THRIVE. I think it's very important that we separate high flow, where you're giving someone high flow and they're breathing spontaneously, to THRIVE. When I have supermorbidly obese patients with a very high BMI, I extubate them routinely onto THRIVE for as long as I can if they've got a safe area to do it in, COVID precautions, etc. So high flow nasal oxygen in the obese is a very useful technique. It's great, and it's wonderful for actually getting them out of hospital faster. There's some evidence from a Ferrando study in Spain that's well worth looking at, that suggested a couple of hours of high flow post-operatively did supermorbidly obese patients the world of good. In our own study for THRIVE, and that's different to someone breathing spontaneous, but when they're deliberately apneic, we found that actually an elevated BMI was the only predictor of failure. Now, it's a cohort study, it wasn't randomized, but it was real patients. And certainly my clinical feeling is that bigger patients tend to do less well with prolonged apnea than smaller ones. We're waiting for some big studies to report on that. But I think if you've got a very large patient, you have to accept that Thrive may not be the perfect method of oxygenation. So a bit like that, moving on to front of neck, I don't have a saturation in mind where I'd want to do front of neck access. But I'd want to be thinking about, is front of neck access going to be possible in this patient? Do I want to, and in resource poor settings, I realize if I think I'm going to need to do front of neck access, do I want to do a transtracheal cannula before we start? Do I want to ultrasound the trachea? Do I want to surface mark the insertion points? There isn't a saturation in my head that says, at this point, I would do front of neck. If I'm failing to oxygenate a patient, then I'll need to do front of neck. But in this scenario, you'd very much hope, have I made a plan? Have I got the best people? Have I got the best resources that are available to me? Should I need to do front of neck? Have I got everyone prepared? Is the patient going to be in the optimal position? So long before you ever get to the, I'm not oxygenating the patient, I must do something else, I want to be at the, I have a plan as to how I'm going to deliver this. I know what I'm going to do. I know where I'm going to stand. I know who's going to carry on oxygenating the patient from above. I know whether we're going to do a vertical slit to identify the cracothyroid membrane or whether we're going to do a stab. I know that I've ultrasounded it to determine the best position. All of those steps are really pre-induction steps in this case, if you think you're going to end up doing a plan D. And as Huafeng was saying earlier, early placement of a transtracheal jet ventilation catheter in the appropriate unit with the appropriate skills may be the right thing, but I don't have a saturation in my head that says at this point, I'll cut the neck.
So I would thank you, Alistair. It's nice that you underline that we have to plan, and somehow we have to set up our conditions for, let's say, come from one plan to the last plan D. But in emergency situation, probably we have no time, and we have to have some clear or at least some points that we have to transfer to the last resources and last opportunities. Could somebody add his maybe not even clear points, but some suggestions when we have to think about front of neck access?
I can say something, but I have to say I wouldn't give a very concrete level of saturation. Again, I don't think that anybody can give a concrete level of saturation, but there would be differences between this case and some other cases of foreign body. In this case, there has never been a desaturation, and I think every one of us would suggest, at least would hope, that this high flow of oxygen would be beneficial in this case. But in other cases of foreign body that you have mentioned in the case discussions and in other cases, we would start already with some desaturation. And this would be, in that case, the clinical feeling, sense of signs, I would say. And you would see if there would not be an increase in saturation after the application of Thrive, I would say Thrive, I would think that Thrive is not beneficial in that case, because to be beneficial, Thrive needs obviously an open airway. And if the high pressure in the Thrive would not be high enough to open the airway, it would not be beneficial, and we would not see any increase. If the decrease in saturation would continue, or if there would be no improvement in saturation, in desaturation patient, I don't think that it would be a good idea to insist to apply Thrive. Just let the surgeon cut, or better, as Alistair has mentioned, do a plan B with some jet ventilation here.
Yeah, in terms of question of when should the front neck be used, I think it depends on your each department, the operator experience. For example, for those report like in the University of Alabama, they do a lot of selective transtracheal jet in the throat cancer patient. For this case, it will be very easy for them to just do elective transtracheal jet. You secure the oxygenation, ventilation, even you give you don't you reduce the rate of foreign body go to the trachea, and you can use muscle relaxant sedation after you secure the jet catheter in the trachea. But if you don't have experience, this is the first time you use, you should not use it, right? Those are differently thinking, depend on your experience. Now, for emergent one, then I think you did quite well that you have a team prepare for emergent track in case something wrong. Those, I think, for this case should be prepared for every hospital in case you need the front neck quickly intubate, quickly do a emergent track, then save the patient if something happens you can handle. There's some question from the live broadcasting transfer to the chat. So one of them is the about using superimposed high frequency jet ventilation in this situation. For those who do not understand superimposed, it's basically a combination of high frequency jet with a low frequency. So high frequency, like it can be 1,000 or up to 3,000 per minute. That maintain oxygenation. So the higher frequency, the better oxygenation. Now on that, the machine can add low frequency jet, like a 12 or 6, 10 per minute. That increase carbon dioxide elimination. So they combine both superimposed and both high frequency and low frequency called superimposed. Those are available in Europe, available in China in 1980s, right now available in Europe for the jet ventilation. I believe this is majorly used for ARDS treatment. For this, it would be similar to use either high frequency or low frequency jet. It doesn't really, unless if you want maintain oxygenation, it might be high frequency. The high frequency, when you have 3,000 per minute or 2,000 per minute, it's basically like a high flow. It just still has a pulse. The high flow has no intermittent pulse. When your frequency high enough, like 3,000 per minute, it's basically HFA low. The low frequency will reduce CO2. The other question, I thought Alistair wanted to discuss a choice of muscle relaxant. I think that's actually one. Do you want to discuss that on the choice of muscle relaxant? This is a really important one. When should you use, or when should you use muscle relaxant?
I think I was just interested in whether you'd use a short-acting or a long-acting muscle relaxant. And I think, to me, it probably comes back to the airway management plan. If my airway management plan is to put the patient to sleep and to thrive them, then I'd probably want to use a long-acting muscle relaxant, because I wouldn't want the patient trying to breathe or anything else when I was trying to manipulate their airway. And I'd be interested to hear if anyone else had alternative thoughts on that.
Yeah, basically,
there's a separate issue to discuss about aspiration risk and things. But to my mind, the risk of aspiration goes up when someone's trying to breathe on an obstructed airway. And I wonder in a sedated, non-paralyzed patient, whether actually the risk of aspiration increases because they're actually more at risk of causing regurgitation because they're not paralyzed.
Yeah, I agree.
There's one more question from live broadcasting side.
Denise would like to answer to Professor McNarry question. Please, Denise.
Yeah, I understand your point, absolutely, because succinyl-choline is getting less popular now, and obviously, usually it's not our drug of choice. But in this situation, actually, we expected that procedure would be shorter, and this is one reason. And the another reason is that probably, we used rapid sequence induction mode, so we didn't sedate him during pre-oxygenation. And probably because of this, we used short-acting muscle relaxant because we thought it would be much shorter.
No criticism of what you did,
Alistair.
No criticism of what you did at all. Just it was kind of to get the discussion amongst everyone attending to make them think about the muscle relaxant they would use faced in a similar situation. And I agree. I think we're all sometimes a bit overly optimistic that our surgeons are going to be much quicker in retrieving things than they turn out to be. I think that's a worldwide problem. But yes, I totally no criticism of what you did. It's more just to make people think that actually what you choose for your muscle relaxant in this situation is an important thing to do as well as everything else you do.
There's one more question from live broadcasting side. If the rigid scope already aimed below the vocal cord, does high flow nasal oxygen still working, or should you use it? Is that still working efficiently?
Question about some foreign objects below larynx in trachea. And the question was, what was? Could you repeat?
The question is, if the rigid scope, if you use rigid scope, the distal end already past the vocal cord, below the vocal cord. At this time, when you use high flow nasal oxygen, does that still work? Is that still working? Maintain oxygenation?
Again, yes. I think it depends. Again, it depends on the level of airway obstruction, and if rigid scope is in the trachea, and there is no space between the airway and the scope. I think there is no any connection with that oxygen that we are given. And I think if there is an airway obstruction, there would be any way of oxygen to go to the lungs.
Your suggestion is not working or much less efficient.
It depends. It depends. If we use like a small scope, like pediatric one in adult patient, and in this case, situation would be similar. The gas exchange would be similar like suspension laryngoscopy. But if we use appropriate size, like large adult rigid scope, perhaps in this situation, airways would be separated from the oxygen that we are given through nasal cannula. What do you think?
I have no idea. That theoretically should be much less efficient, right? You don't have much space between, from your high flow to the lung, because the rigid scope block the major airways. However, I don't know. The high flow nasal oxygen mechanism and high frequency jet, the mechanism of oxygenation is not fully clear. Right? Before, you never think people is paralyzed, never have no breathing effort, but you can maintain oxygenation for as long as 17 minutes. So it has special mechanism. I don't know whether this special mechanism is highly efficient enough with that little space between rigid scope and tracheal wall can maintain adequate oxygenation. I do not know. Anybody else has any thinking about this?
Maybe
Yeah.
I can say something. I think very theoretical, maybe, but I think in that case, using Thrive would be even risky. It would have two risks. First of all, if a foreign body on the glottis, so it would maybe insert, it would pull the foreign body further to distal area. On one hand, it can be good so that if it is possible to insert it in one lung, then at least we would have an airway with the other lung. This would be a good idea, but on the other hand, it would be more difficult to get the foreign body outside. This is one risk. The other one, if the foreign body would seal the whole airway to stop the gas exchange, and if you still push some high flow, high pressure air, gas into that area, there would be maybe just theoretically a risk of a fistula of the airway. And I think, I'm not sure whether this can be efficient, but I think at least theoretically this can be a risk.
Okay, thank you, Professor Senturk. But colleagues, we have to at least mention another option beside Ventrain. Now it's became available, not in Ukraine, obviously, such a three-tube technology when ventilator with computer estimating pressure and some negative pressure application. Such tube could be could be put beside some foreign body because it's like just 4 millimeters in diameter, and like normal ventilation could be conducted because a ventilator calculated pressure to be close to zero, small positive at inhalation phase and small negative at exhalation. But in contrast to all previous negative pressure device, such device is designed not to evoke lung edema because of negative pressure. So if such device would be available in some big hospitals, it could be considered as alternative. Do anybody have his own experience beside my theoretical consideration?
I have some experience in this area. In the late 1980s, I involved invention of high-frequency two-way jet ventilation, which is published in Critical Care Medicine in 1992. The basic idea similar to the current machine you mentioned as active expiration. Basically, high-frequency two-way jet ventilation, you have in the inspiratory phase, you have a jet into the lung. But during expiration phase, there is a jet catheter. The jet opening is in the cranial area, but it's the reverse. It jet out of the lung. So active expiration. So that will generate basically a negative pressure during expiration in the lung, but overall mean airway pressure is zero. So that had been shown in animal, in dog, and in patients compared to regular jet ventilation, significantly increased oxygenation and significantly increased carbon dioxide elimination, significantly improve hemodynamics like blood pressure that have been shown in a normal NSI patient, but that not being studied in treatment of ARDS. We, Bailin and I, have a new publication just published, analyze all the oxygen strategy, ventilator strategy in COVID-19 patients. In that paper, if you're interested, you can go to look at it. We think the high frequency two-way jet ventilation may be the current machine that give you negative pressure aspiration, the active aspiration. That basically is, one is conventional, one is a jet, it's open system, one is not open system. That may give you a better treatment outcome in ARDS patients. I saw some news report about the machine in Europe has a better outcome compared to others than but those are from companies, not a real final publication. I don't know whether anybody knows. A new publication, scientific publication, shows that is better than a regular ventilator to improve oxygenation ventilation in ARDS patients. I don't know. I don't know anybody else have heard any access to any new publication on that machine. No, probably still under investigation. Yeah, but that's the idea. The idea is similar from jet and the conventional ventilator. Yeah.
Thank you, Huafeng. And we have one of the last.
And Mert has some questions. Okay, so she said maybe you unmute yourself. Maybe too late. Is that what you say?
I just said okay. I'm fine. Okay, thank you.
Okay, yeah, it's close to 2 hours, and Max, what do you think?
I think we have to finish on the last question, maybe not so hard, and we have to give a final, simple and correct answer. And the question is, if TRI is still effective, what is the head position of the patient for this surgery? Dennis, could you answer for this question?
Yeah, sure. The position is usual for interventions of that kind for microlaryngoscopies. It is supine position, and normally we place a small pillow under the patient's shoulder, and that's all. And after or basically during laryngoscope insertion, a surgeon may adjust the level of to what extent head is extended. Yeah.
Thank you for short and clear answer. And Huafeng, could you please conclude our meeting? And thanks. We are thankful for involving us to let us present and to share experience and receive much experience from you. Thank you, everybody.
Okay, I would thank the host, Max, and presenter Dennis, Max, and the expert, Hongguang, Mert, and Alistair, and all experts here, and all the volunteer contribution. They spend a lot of time, also try to transfer the question from live broadcasting, translation into different language. I think the purpose of this IAMS organized this discussion in several. One is promote teaching, training, exchange idea among the our founders, among different institutes internationally, especially during this pandemic period that we cannot travel. And then also this will let us to meet periodically to see each other, say hi, and can take care and the best wishes to each other and care each other. And this will be every 3 months. So anybody here, you are welcome to be host institute to present your case. The next one will be in March, every 3 months. I think currently Mert from Turkey and people from Pakistan are interested in host the next one. And if your institute is interested in host the case on difficult airway management, please let me know. You can send me email and send your case to me. I will discuss with the expert and we will recommend one for next one. And this way, you, your institute, you as a host, a presenter will help the other people learning, training, and help. We see each other periodically, and also will assist your introduction of your institute to the world. I want again thank you everybody, and thank you every the organization, especially the Miller Anesthesia Association in China to make it live broadcasting. This is led by Dr. Liao that make it live broadcasting to the world. So we hope this case discussion will getting better and better. We gain more and more experience, and we hope it will be helpful for everybody around the world who are interested in airway management for the learning and exchange of idea with other colleagues. Thank you all so much.
Excuse me, Huafeng, just one point. So if you mentioned that at the first meeting, it was very high, 6,000 of viewers. But now we just read from technical support that it's unbelievably 46,700 viewers. So
that's correct. I just saw the live broadcasting site, 47 Soren.
Thank you,
audience.
Thank you.
So, yeah, I will thank you all for your contribution. Thank you. We have 47 Soren. But if you look at this live broadcast site, in the sometime later, some people will come to back, maybe check the recording. And the last one, we have 120 Soren at the last. The right now at the live is 47 Soren and 200.
Thank you.
Now. Thank you. Okay, you all take care. This is during this pandemic, second surge. Yeah, you all take care. Our best wishes to you and your family, everybody. Thank you so much. See you. I'll say bye-bye.
Thank you.
Bye-bye. Thank you. Take care.
Thank you, and stay well, everybody.